Hello and welcome to my presentation entitled A Literature Review of Psychosurgery for Major Depressive Disorder and Its History. My name's Eamon Canali and I'd like to give special thanks to my clinical supervisor, Dr. Ranjit. So the sources I've used for this presentation have largely been the biography of the man who popularized lobotomy, Walter Freeman, and his Lancet article from 1948. I've also used some more recent literature reviewing the efficacy of neurosurgery for major depression, and another couple of related bits on the relevant neuroanatomy. So the aims of this lecture are to give you an overview of the history of the lobotomy, partly because it's important to understand the public's perception of it, but also because it's a bizarre and quite entertaining tale. To explore the relevant neuroanatomy and to look at the future of research into neurosurgery as a treatment for psychiatric conditions. So if we're going to explore neurosurgery as a potentially viable treatment for psychiatric conditions, I think it's important to look at the history of lobotomy and understand why public perception of it is the way it is. It was performed by its inventor up until 1967, so it's shockingly recent. I was quite amazed when I found that out. You know, the Beatles are in the charts by this point. And mostly the public think that lobotomy always resulted in the patient being essentially a vegetable. I did before I got researching this, partly from a couple of the films I've listed below. Those were just a few off the top of my head, but there are more. So this is the man who popularized lobotomy, Walter Freeman, and I'm calling this summary of his life's work A Career of Red Flags. He started out as the grandson of William Williams Keene, who was the first man in most likely the world to perform a successful removal of a brain tumor. That was in 1888, before any type of imaging or even electric lighting. So Walter Freeman was a medical student drafted into the medical corps of World War I, and he became a sergeant but was demoted after threatening his company commander with a shoe. That was the bit of information that drove me to read his biography. I couldn't just gloss over that without getting more detail. The story itself wasn't that great. It was just that he got angry at an officer who was making noise when he was trying to sleep, and he picked up a shoe and didn't throw it. But it's not the only incident of shoe-related violence in this story, so hold on for that. He was a biographer's dream. He obsessively diarized his entire life, so there's a lot of anecdotes that his personality really shines through in. Ignore the bits in bold, those are just prompts for me to read some of my own notes. I've structured this not quite chronologically, but in a way that allows you to understand Freeman the man before we go into what his life's work was. He was the eldest of 7 siblings. He was always emotionally distant with his mother, and years later he wrote in his diary that he never loved her. Walter Freeman III, his son, said, "My father didn't have the capacity for a close emotional tie. He was always somewhat distant." He appears to have had a very formal and distant relationship with his father. There's a bizarre anecdote of Freeman's school days when he was caught by the truant officer, and to express his anger, Freeman Sr. Whipped himself in front of the boy. He was much closer to his grandfather, Dr. Keene. Dr. Keene was a big name in medicine, and Freeman kind of rode on his coattails to become successful. Freeman's personality seems best characterized by recklessness. He would drive recklessly. He once poisoned himself in lab work when he accidentally put the wrong end of a pipette in his mouth. When his father was dying and he was asked to shave him, he did so in a rushed manner and made a mess of it. And when he was bored at the hospital, he would sometimes pour urine samples down the drain instead of processing them. His character was described as a neighbor as indifferent, aloof, conceited, peculiar, and eccentric. Despite keeping comprehensive diaries throughout his life, he wrote very little concerning the deaths of his grandfather and mother. In 1946, when his son died tragically by falling over a waterfall, his biographer puts forward that he threw himself into his work and never allowed himself to explore his deeper reaction to his son's death. But I suspect that there simply wasn't one. I think his biographer projects a bit more humanity onto Freeman than was actually there. In 1968, when another of Freeman's sons died at the age of 31 of a brain tumor, Freeman attended a medical conference in Florida instead of attending the funeral. So the first big red flag of our story is this anecdote about Freeman seeing a patient who was presenting with a paraphimosis induced by his fiancée putting a wedding ring over his appendage. Freeman treated the chap by filing through the ring and getting it off with forceps. The patient asked for it back, as you can see from this quote, but Freeman lied and kept it, had his family crest engraved on it, and wore it for years, either around his neck or from his waistcoat pocket as kind of a public souvenir. Here are some further red flags. He considered himself a real showman and so did some of the most unprofessional things imaginable just to get a reaction. He used a carpenter's mallet to perform some lobotomies. He accidentally killed a patient when he stepped back to take a photo and allowed the instrument he was using to sink deep into the patient's midbrain. And on multiple occasions, he accidentally broke the same instrument by manipulating it too hard inside the patient's skull. Here are a couple more examples of Freeman's recklessness. He used ECT on a patient when there was no one around to assist him or any anesthetic, and the patient immediately broke both their legs during a convulsion. He gave her some morphine and just kind of wandered off. When he came back, they, not, unreasonably, were very angry, so they sued him. But Freeman learned no lessons from this, and his only takeaway was that he should have performed lobotomy instead. He also treated his own aunt for depression with metrazole therapy, which was used as a shock therapy just prior to ECT becoming available. And part of the reason it stopped being used was because it caused uncontrollable terror before convulsions. And this is the other incident of shoe-related violence. When George Washington University Neurology Ward was being built, and he had had some input on the design, he requested shatterproof glass on the doors, and when this wasn't put in, he asked a nurse to remove her shoe and smashed several of the panes with it. I'm unsure why he didn't use his own shoe, but I thought that was a fun story. Freeman considered himself a real showman and had a habit of performing what I'll charitably describe as stunts during his lectures. On a couple of occasions, he started small fires during lectures by putting a lit pipe in his coat pocket or emptying the pipe bowl into a ventilation shaft. On one occasion, when he was trying to demonstrate certain infantile behaviors in dementia, he had an elderly patient with him and documented this. I pulled from my hip pocket a nursing bottle full of warm milk and fed it to the greedy old lady. He wrote that in a letter to his wife. He cheated on his wife constantly, and she became an alcoholic. Later, when she died of complications from that, he arranged for an unnecessary post-mortem. And although he wrote the last quote there about patience, I thought it was more telling to put it next to that note about his wife. These are some accounts of Freeman's manner when he was working from people who were there at the time, and they reveal a complete contempt for any kind of communication skills or basic surgical procedure. I won't read these out, but if you can pause the show here if you want to read them in more detail. In 1924, at the age of 28, Freeman worked as the senior medical officer in charge of St. Elizabeth's in Washington. This was a big hospital, a very prestigious role for him, and it was arranged by his grandfather. Um, what was interesting discovering through his biography is that he didn't actually want the job. He'd, at this point in his life, just been left by his then partner after he proposed to her and she said no. He had wanted to actually go into a professorship. He approached a lecturer that he had idolized during his studies, but was passed over for the job. And these events maybe go some way towards explaining his attitude towards the job and his patients. These quotes show kind of a contempt for psychiatric patients. And the second quote about this being them being kind of a underused resource was actually kind of a product of post-war thinking. And it was shared by Adolf Meyer, the man who was champion of the biopsychosocial approach to patient care. When discussing autopsies at St. Elizabeth's, he diarized, "Patients with mental disease are often poorly equipped to discuss their symptoms. I used to remind the students that we had to rely on objective or laboratory findings rather than upon the history. It's like veterinary medicine, I would say." So he doesn't really see them as people. And the Jiffy spinal tap is another illustration of that. He was an advocate for suboccipital puncture or cisternal tap, so that's collecting CSF high up in the neck. It was much more risky than using lumbar puncture, but it meant he could do it alone without assistance, which was a theme that developed through his career. So, in his role at St. Elizabeth's, he initially worked under Dr. von Jauregg, the first ever psychiatrist to win a Nobel Prize, and that was for using malaria as a treatment for neurosyphilis. So, I mean, the downside is you've then infected that patient with malaria, but this was an impending crisis. All of these patients with neurosyphilis that were starting to fill up every asylum. This is a bit of a digression, but it was too fun an anecdote not to include. So the way that they got malaria to the hospital, they transported 12 mosquitoes carrying malaria from Puerto Rico in a 10-ton truck. That was apparently the only public health vehicle available. 11 of the 12 mosquitoes died in transit when they were left in a container that had sticky tape inside of it, and they became stuck to it. A single mosquito then infected a patient without syphilis, whose blood was then used to treat other patients with neurosyphilis. Of the events, Freeman wrote, "What happened to the mosquito is not recorded." Freeman didn't actually, strictly speaking, invent the lobotomy. Its precursor was the leucotomy, invented by a Portuguese doctor called Moniz, and that was developed after he saw at a conference some chimpanzees that had their frontal lobes damaged. And he then went back to Portugal to develop this on humans. And I think it's important to give this some context as to how Moniz was able to put this forward. He was a incredibly powerful figure in the Portuguese political landscape. He served as minister to Spain, minister of foreign affairs, and was even Portugal's signatory in the Treaty of Versailles. His initial leucotomy study was of 20 patients. He pronounced 7 of the patients cured, but didn't examine them beyond a 11-day follow-up. Several were worse than prior to the surgery. It's also worth noting that on one occasion he was shot 4 times by a disgruntled patient in 1939, which he survived and then went on to win the Nobel Prize. He also, and he probably should have won the Nobel Prize for this, pioneered cerebral angiography. At the time, injection of something called thorotrast was used instead. And that was known at the time to be radioactive and carcinogenic. Despite angiography becoming available, Freeman persisted in using injection of thorotrast. And again, that's a recurring theme of him not adapting to advances in his field. So how is leucotomy different to lobotomy? Um, there is very little difference, really. They were both surgical procedures with patients under general anesthetic, incisions made over the frontal lobes, and then small lesions made at various points. Um, they just changed the name to distinguish their work from the work of Moniz. Freeman worked with a neurosurgeon named Watts, who actually seems to have been Freeman's counterpart. He was reported to have been a very diligent and caring professional. So together they performed their first lobotomy in 1936 on a patient with this history. They most certainly did not consent to the procedure. Their capacity is up for debate, but it seems that they did have capacity. But those questions weren't really asked in the same way that they are now, especially for female patients. This patient survived 5 years after the operation, and reportedly they were the best of her life. I think that was reported by her husband, though. Um, they announced their initial findings at the Baltimore Southern Medical Association conference, and I just include this to show that, you know, the reception to these ideas was kind of what they would get today. People were horrified. It wasn't, universally such a barbaric time. Um, Freeman loved publicity and often announced findings via popular, press rather than medical journal. So making the headlines at a convention was a big win in his book. Whether they were conscious of it or not, Freeman and Watts did target female patients. They comprised 17 of their first 20 cases. And they generally went for patients who were a problem to manage on the wards. There's this story where he casually assaults a patient who was a large woman whose aggressive outbursts the ward couldn't manage. And he would repeatedly lobotomize patients who had relapsed, although the definition of the indications and results were so vague that I guess relapse just constituted somebody becoming a bit difficult again. I include this first quote from Freeman because it illustrates his utilitarian attitude towards patients. If he could get someone, as he termed it, usefully occupied or into paid employment after the operation, that, as far as he was concerned, was a huge success. So during the operations, he frequently asked people to recite the Lord's Prayer, which is incredibly creepy, and unsurprisingly, some of them became so anxious that they then had to undergo general anesthetic. Um, and their indications for the operation were very ill-defined. They experimented on performing it on children, or wanting to perform it at various stages of disease process. They were just kind of making the things up as they went along and seeing what worked. Any defense that they might have had about this being a pioneering procedure, or that mistakes were inevitably going to be made in the name of progress, kind of go out of the window when Freeman really goes off the rails and makes the transorbital lobotomy. So transorbital lobotomy or leucotomy was based on findings from this Italian doctor who Freeman corresponded with. This comprised of putting a sharp instrument that they termed a leucotome through the upper part of the eye socket and just kind of wiggling it around. Rather than using anesthetic, they just gave the patient a round of ECT before and after each side. The instrument I mentioned there, the leucotome, was essentially just an ice pick, and that's what Freeman started using when he first began experimenting with this procedure. He wanted a fast way to do it and to use it earlier in the course of disease progression. That was completely at odds with what Watts proposed. He wanted it to be used as a method of last resort, along with Moniz, but Freeman wanted this to be used, first step. So in January of 1946, he started doing transorbital lobotomies, as I just described, in secret from his partner Watts in the office that they shared, and he would send the patients home in a taxi. Um, just as a side note, he later began having an affair with the first patient he tried this on. I feel like I had to include the word consensual there just because of all the other horrible stuff that he did. Um, of his fourth transorbital lobotomy, the patient had complications of bleeding, had to go to hospital, and was left permanently disabled. Of that event, Freeman just wrote, "They recovered well enough," but they definitely didn't. During the 10th case, Watts walked in unexpectedly, and Freeman was unfazed. He just asked him if he could hold the ice pick while he took a photo, and Watts was understandably horrified. That's just a picture of an ice pick, if anyone wasn't sure what they look like. I took that in my kitchen for science. So this incident effectively ended Freeman and Watts's partnership. Freeman loathed the idea of using surgical precautions like any aseptic technique, and Watts, as a neurosurgeon, found that, you know, as horrifying as you would imagine. Um, Freeman, at this point, just goes on the road and teaches transorbital lobotomy to anyone who will listen to him. He becomes very popular for a time and covers just thousands of miles teaching this all over the United States. Um, Again, covering thousands more miles all throughout the rest of his career following up these patients. Which I suppose shows that he did care about these people, but I think it was more of a narcissistic thing. He cared about them insofar as how they reflected on him. Freeman published the technique of transorbital leucotomy in The Lancet in 1948. I just thought it was a funny coincidence that that was 100 years exactly after Phineas Gage's accident. And it seems in those 100 years, it was kind of the Wild West for experimental brain surgery. Um, in the article, Freeman cites Ducoste, who used a similar technique to put malaria-infected blood straight into people's brains. And Freeman claimed that the personality changes from transorbital lobotomy were less severe than in the more open surgical procedure. So these are quotes from that Lancet article. I won't read them all out, but you can pause it and read them at your leisure if you like. They just go to show the kind of vague way that Freeman classified his results. The indications for the procedure were very broadly defined. He put the contraindications as well. Emotional dilapidation was the most outstanding contraindication, um, and I think the reason for that is that patients with what he called emotional dilapidation were the more withdrawn people, the people who were easier to manage in an asylum setting. So they were not the people that Freeman wanted for this procedure because in part that was his intended outcome, to make them easier to manage, less uncontrollable on the ward. So this illustration is taken from the article. Unfortunately, I don't know who did the illustration. I know it wasn't Freeman because I've seen some of his other drawings and they're just terrible. Um, but he was aiming for the dorsolateral and anterior prefrontal cortex. Um, And his hypothesis for this was that it was cutting the connections between the thalamus, which he thought was the origin of uncontrollable emotions, and stopping them from interfering with the frontal lobe, which actually isn't a million miles from the distant relative of the lobotomy that we still use today. So I'll go into more detail on that later. I think the neuroanatomy of it is very interesting. I also find it quite unsettling just how there's no glove on the hand in that illustration. Um, Again, just showing Freeman's contempt for any precaution. I include this illustration just because one of the notes from patients that underwent the procedure was that they often got eye infections in later life, and I think that's because he went through the accessory lacrimal glands, So they probably would have gotten dry eyes and infection that way. Freeman was a very prominent figure in psychiatry at this time. He actually served as president of the American Board of Psychiatry and Neurology. Um, During his career, there were somewhere between 40 and 50,000 lobotomies performed across America. As much of a workaholic as Freeman was, he was only involved in less than 10% of them. Things weren't quite so extensive in the UK, but there were quite a lot of lobotomies performed in London. This chap, McKissick, performed over 1,300 of them, whereas Freeman obsessively followed up his own patients. McKissick's partner was a chap named Maurice Partridge, and he wrote of a misidentified patient this anecdote. On one occasion, in a district of Swansea, where all the streets looked the same and everyone was called Jones, the writer was misdirected. The lady who opened the door of the house seemed quite unfamiliar, but offered a cordial welcome, saying that she remembered being in hospital and that she was delighted at the reunion. There was 10 minutes' talk of the rather intimate topic of vulvovaginitis before it was possible to persuade the patient that we had never met before. So that was the only documented story I could find, of lobotomy reaching Swansea. Reading up on this, I was very surprised that the story of Rosemary Kennedy is not better known. Um, Rosemary Kennedy was the sister of JFK. She had, I think, very mild learning difficulties. She suffered some kind of anoxic brain injury at birth and subsequent developmental delay, but she was certainly functioning very well. We have quite eloquently written letters by her. She was able to travel overseas without a chaperone. She was studying to be a nursery teacher. Overall functioning, you know, this wasn't holding her back anyway. She was epileptic, and at the age of 22, it was noted that she was becoming increasingly violent and aggressive, possibly post-ictally, but possibly also just rebellion at the stifling environment she was in. She was then sent to a convent school, but she began sneaking out, and the nuns suspected her of spending time with men. The family feared a illegitimate child. Her biographer writes that they found her sexuality dangerous. So JFK's father, Joseph Kennedy, took Rosemary to see Walter Freeman without her mother's knowledge. Freeman quickly diagnosed her with agitated depression and performed a lobotomy on her in 1941. And she very sadly was a vegetable after the procedure, completely incapable of living independently. Her parents very successfully covered this up and just told everyone that she moved away. And this didn't break out into public knowledge until the late 80s. It's thought that the Special Olympics may have been made in her honor, but that's not widely publicized. JFK's last act in office was actually the Community Mental Health Act of 1963. It was intended to reduce institutionalization, but unfortunately, the patients were released into communities ill equipped to deal with them, and a lot of homelessness ensued. So by the 60s, Freeman was a thoroughly fringe figure. Antipsychotics had come around, and everyone had moved on from lobotomies, really. But he insisted on continuing and thought that the pendulum would swing back and everyone would come round to appreciating lobotomy. In 1960, he lobotomized a 12-year-old boy after diagnosing him with schizophrenia on the basis of one short interview. In 1967, he performed a third repeat lobotomy on a woman in her 60s. She died of a hemorrhage, and that was the tipping point where the hospital finally revoked his surgical privileges. Um, at the time of his death, there was a lawsuit in preparation against Freeman, but he never faced any charges for his many, many crimes, which is sad, but there's a quote I'm fond of that's just the way the cookie gets completely stomped on and obliterated. When I was recording this, I realized that this talk is actually quite long, so now would be a good time to maybe take a break and get a coffee if you want one. Okay, so now that we've got the fun stuff out of the way, let's get into some heavy neuroanatomy. Um, I've looked at a meta-analysis of all of the evidence for neurosurgery for major depressive disorder. Um, and there's mostly just small studies. As you can see, none of these are from Freeman's time because they were all quite so crude back then. Um, but there's a decent amount of evidence. The procedures involved in these trials are the four I've listed here. They generally report an efficacy of somewhere between 30 and 60%, which is not quite as good as you would hope for invasive neurosurgery, but you also have to bear in mind that this is a very treatment-resistant population that are involved in the studies. As I mentioned earlier, Freeman's reasoning for performing lobotomy was to sever the connections between the thalamus and the frontal lobe, and our current understanding is that it severs circuits belonging to what's called the corticostriato-thalamocortical loops. So to really understand what that actually entails, let's look at the bits of neuroanatomy involved in each of the parts of that term. This is a classic diagram of the limbic system. I've never particularly liked this diagram because it's so abstract and you can't really picture where anything is in the brain. But it is good for showing how close the hippocampus is related to the amygdala there. In the previous image, in the sagittal view, it kind of makes it look like the fornix just stops abruptly. So I wanted to try and do an illustration of something showing the 3D nature of it and how it curves in and sticks out again. So overleaf is my attempt at that. So here is my illustration of the hippocampus curving around into the fornix and then sticking back out where it reaches the mammillary body, with the thalamus in the middle, and you can see the anterior cingulate around the outside. Skulls are more fun to draw than brains, so that's just me procrastinating there. Whilst Freeman thought that it was the thalamus that was the seat of the emotions he wanted to disrupt, it seems more that it's the hypothalamus that it's appropriate to think of as the kind of lizard brain that drives this emotional output and some of our base evolutionary instincts. Um, the hypothalamus receives input from the amygdala, um, which is involved in attaching salience both to positive and negative stimuli. And the amygdala is then, in turn, inhibited by the medial prefrontal cortex, or not, as is the case in PTSD. This diagram looks awfully complicated, but if you just look at the hypothalamus part of it, you can see you've got the input from the amygdala there, and then the communication with the prefrontal cortex on the left. So those arrows from the thalamus to the prefrontal cortex is what Freeman may have at times successfully, probably more accidentally than through design, disrupted. This illustration is just pointing out some areas involved in what's been termed the fear network, so comprising of the amygdala, the hypothalamus, the insular cortex, and the prefrontal cortex. Functional imaging studies have shown that the anterior cingulate cortex, which is targeted in anterior cingulotomy, activity in that area increases with low mood and decreases following response to SSRIs. And studies of OCD patients have shown increased activity there when triggered with certain anxiety-provoking phrases or certain stimulus. So in corticostriato-thalamocortical loops, what really is the striatum? Well, it's part of the subcortical basal ganglia. It's made up of dorsal and ventral parts. The dorsal is mostly caudate nucleus and putamen, and the ventral is pretty much just nucleus accumbens. Technically, also the olfactory tubercle, which is why smells can be closely associated with emotion for people. But for what we're going to talk about, it's just the nucleus accumbens. And it's the ventral striatum that we're going to be talking about as part of this system regulating emotion and motivation. So here's the basal ganglia, and the nucleus accumbens would be just tucked under the putamen there. The nucleus accumbens is made up of two distinct parts, the core and the shell. So the shell is part of the limbic basal ganglia, and has been termed the misery fleeing system. And the core, part of the extrapyramidal ganglia, is part of the reward seeking system. And we'll come on to why this is important in a moment, because they're involved in very different circuits. I just like this illustration because it quite nicely shows that the nucleus accumbens is made up of both core and shell and distinguishes them. So if you think of all of this coming under the umbrella of the corticostriato-thalamocortical circuits, you've got two distinct groups in there. You've got the extrapyramidal system, which is reward seeking, and that hasn't changed much from an evolutionary standpoint in the past 54 million years. It's involved in movement, and animals would move towards food to seek reward. So hyperactivity in that section of the pathways has been shown in drug craving studies. And inactivity in that area leads to anhedonia and anergia. So it's the core of the nucleus accumbens, which is part of the extrapyramidal basal ganglia. The other section of them, the limbic or misery fleeing system, involves the shell of the nucleus accumbens. So hyperactivity of the misery fleeing system creates low mood, dysphoria. All of these four procedures are just different ways of trying to interrupt those pathways. So you've got the anterior capsulotomy, targeting the internal capsule, anterior cingulotomy, going for the anterior cingulate cortex. Just underneath that is where they go for subcaudate tractotomy, and then a combination of the above two is limbic leucotomy. This is to show you how the internal capsule relates to the corticostriato-thalamocortical circuits. I need to start using an abbreviation for that, it's a mouthful. This slide is showing the locations of those procedures on the coronal plane, just on some imaging. I realize I'm going through these slides quite quickly, but if I've done this right, hopefully it shouldn't be too hard to pause and just look more if you need to. This is to show exactly where subcaudate tractotomy takes place. So the descriptions I've found are that it's just inferior to the anterior cingulate cortex. But inferior to the anterior cingulate is the substantia innominata, but it's not targeting that. It's targeting just in between, which doesn't really have a name of its own. It's just the area under the anterior cingulate cortex. And this is just showing you the internal capsule again from the coronal plane. Deep brain stimulation has also been used to try and target these areas. The largest study I could find to date had 201 participants. Sadly, it didn't show any statistically significant efficacy after either 6 or 12 months. But after it failed, they continued for another year, not blinding the experiment and varying the amount of stimulation given in the deep brain stimulation. And then it did actually start to become more effective. They got a 48% antidepressant response, and a quarter of the patients achieved remission. So there's potential here, but I wouldn't hold your breath either. Part of the tragedy of Freeman's legacy is that it has stifled any research on what could be a more promising field. Having looked at the anatomy, I wanted to just make a note of the blood supply as well, because I couldn't help but wonder which vessels was Freeman cutting and having these catastrophic hemorrhages from. And the more I looked into that, the more I began to dislike this diagram of the Circle of Willis. Um, it's very difficult to picture where any of that is in real terms related to the rest of the brain anatomy. So I've reimagined it on the next slide. So here is my spin on the classic Circle of Willis diagram. And I think it was either the anterior communicating artery or the anterior cerebral artery that Freeman was putting his ice pick through. My illustration also has the benefit of being much more creepy than the classic one. As well as deep brain stimulation, there is potential in MRI-guided focused ultrasound. So rather than having to do open surgery, you can just target with powerful ultrasound areas that you want to create a lesion, and you can even modulate the power of that so that you don't cause a lesion and instead see what effects that would have before you make an irreversible lesion. And similarly, gamma knife would use radiation to cause a very precisely targeted lesions. And that's been tried in OCD, but not used yet for major depressive disorder. So thank you for listening to my presentation. Normally I would ask for any questions at this point, but I guess in this case just Google it or email me if you want any further information. I've included a couple of anecdotes there. Freeman himself very rarely drank, but he included this in his diary. I mean, that's his side of the story, so God knows what he was actually doing. It's also just to show you that I use my ice pick for what it's intended for and nothing more sinister. So thank you all. Ta-ra.